Thanks for joining, like I said, on the last evening of your term. I suppose this is a really important topic because it comes up quite a lot, but also it's a very useful core skill to you all as F1s. I think I've had conversations with this before with Anush, and I think he seems to have, I agree with him actually, that a lot of ECGs for exams can be pattern recognition. But what I hope to cover today will take you beyond the pattern recognition, because I think whilst it might be good for SBAs, it certainly isn't good for when you're on the wards and when you're the F1 in A&E and you have to actually analyse the ECG. So just looking through what you've talked about in terms of your confidences, I'll post it again. Mixed bag. Most of you are relatively happy with sort of the electrophysiology of the heart, but in terms of OSCE stuff and systematically evaluating an ECG, which the whole thing is about, you probably need a little bit more help with, which I'm very happy to provide. So this is the structure that I'm going to go for today. I'm going to give you a bit of background, so how to record an ECG, what the leads actually mean and how we can remember them to make it a lot easier for us in the future and not require rote learning, and a normal ECG trace. And then we'll cover with the meat of the session, sort of systematically assessing an ECG. There's 59 slides in this PowerPoint. I'm not intending on going through them all. I'm just hoping that it will be a useful resource for you to look back on for the minor points, the stuff that's a little bit more low yield but might be useful to know. Okay, so let's begin with setting up an ECG. Oh, sorry, yeah, the other point is I've got a lot of questions on Menti, so keep that open. So setting up an ECG, you've got 6 electrodes that you put on your chest and 4 electrodes that you put in your limbs. Limbs are quite easy. Ride your green bike. So starting from your right arm, ride, and then going clockwise, your green bike. And then you want to put them sort of on your wrists or the ankles. That's probably the fiddly bit when you're actually doing it on a patient, because if they're positioned awkwardly, they might come off. In terms of the chest electrodes, V1, V2 are either side of the sternum at the 5th intercostal space. V3 is a bit funny, so just go straight to V4, which is the intercostal space below and in the midclavicular line. And then you can go back for V3, which is between V2 and V4. And then from V4, it's the same level. V5 is anterior axillary line, and then V6 is mid axillary line. So just practice doing that a little bit. Picture how you'll do it. Maybe practice on a housemate or something like that. Just do it a couple of times and then it'll be really easy. Okay, that's all you need to do. So it's the 4 limb leads, ride your green bike, and then the 6 chest leads. Okay. But with the 10 electrodes, how do they actually give us the 12 leads that we see on the ECG? The chest leads are fairly easy to interpret. They just sort of measure the electrical activity in the horizontal plane, and it's just corresponding to where they're placed. So as they're placed alongside the chest, it's going to pick up the electrical activity sort of from the chest wall it's over. The limb electrodes are a bit more confusing, and it's combinations of the electrodes which are used to generate the other 6 leads. Okay, so we'll start with the standard limb leads. The rule with them is it's always going to go to the left, and if there's a leg involved, it's going to go down to the leg. Okay, so first one is right arm to left arm, nice and straight, it's just a straight line. The second one is going to be the right arm to your left leg, going down, and then your third one is going to be your left arm to your left leg. Okay, so going in the other direction. The augmented limb leads also have a similarly nice rule. So it's always to do with the last letter of the lead. So AVF, foot, AVL, left, AVR, right. Okay, so so let's say we're doing AVF, so it's the foot one. Draw a line between the other 2 electrodes. So you draw a line between the limb electrodes, and then the sort of direction of AVF is a line from the other 2 electrodes going down in the direction that it indicates. So foot is going down to the foot from the other 2 electrodes. Left wrist is going to the left wrist from the other 2 electrodes, and AVR is going to the right wrist from the other 2 electrodes. And the reason why this will be easy is once you have this in your head and you can draw it, then you never have to worry about rote learning positions and regions for MIs. You never really have to worry about axis. All of it will make sense if you understand how you generate these limb leads. Okay. If there's any questions at any point, just pop them in the chat. What about the right electrode? Right leg, sorry, electrode. What do we use that for? So we've generated the 12 leads from actually just the 9 electrodes, the 6 on the chest, and then your right wrist, your left wrist, and your left leg. Do we know what we use the right leg electrode for? This is just general knowledge. It probably doesn't matter so much. Neutral, yeah, both of you are absolutely right. So we call it the Earth or the neutral, and it helps us reduce interference. So it makes our lines a little bit nicer and clearer to interpret. Very good. Okay, so let's now talk about the cardiac electrophysiology. So all I'm talking about is the flow of depolarization through the heart. So where does depolarization start? Where does the beat of the heart originate? SAM, very good. The sinoatrial node. And where is the sinoatrial node? Very good, all of you. Where in the heart is the sinoatrial node? Good, the right atrium. And this is what my green button, green spot indicates. So from the right atrium, very good, all of you, it goes and spreads across to the atrium. Okay, spreads out in a nice sort of pattern. From there, it goes through the atrioventricular node. The atrioventricular node sort of holds it up a little bit and then transfers it down really quickly, and then it sort of depolarizes from the bottom of the heart up. The last sort of most important step is that you've got repolarization of the heart. And the thing that sort of is echoed in the ECG trace is repolarization of the ventricles because they're such big muscles. Okay, so you'll have it going back up from the direction where it first depolarized, so from the bottom of the heart up. Okay, so let's now consider how all of that movement in the heart actually gets translated into the ECG trace. So basic rules are: if the depolarization travels in the direction of the electrode, so if it's going in this direction, then you're going to get a really strong positive deflection. If it's going in the opposite direction, you're going to go the other way, so it's going to be negative below the sort of trace. And then if it's perpendicular, it's just you're not going to see a reading at all, so it's going to be isoelectric. Okay, so with your atrial depolarization, let's consider it in lead 2 because that's the one that we use for a lot of the pacing strips. It should give us sort of the clearest ECG trace. Okay, so the first step is your atrial depolarization from the sinoatrial node. And because it's sort of spread out, it's not this one uniform direction, but it's broadly going in the same direction for lead 2, you do have a positive deflection, but it's not too big one. It's a small little jump. Okay, and then the next big step is our QRS. Okay, so shooting down to the ventricles, that's a really strong impulse, and that's going to give us a big positive deflection because you can see it lines up very nicely with the direction of lead 2. The reason why it goes up and then suddenly down is because the up is when it's going down to the bottom of the heart, and then the going back down is when when the depolarization is traveling from the ventricles all the way up. Okay, the last step, which can be confusing, is the repolarization. Okay, so it's going in the opposite direction to lead 2, but it's still a positive deflection. Can anyone tell me why? And the colors might help with this. So why do we still have a positive deflection in the T wave, even though the arrows are pointing in the opposite direction? Fantastic, yeah, because it's repolarization, yeah? So all of this, the green arrows are depolarization, it's a positive deflection, exactly. And then the repolarization is going back negative, so the direction is, yeah, no worries. So the actual polarity is the opposite, which is, so a double negative makes it positive again. Okay. This is useful for us to consider for several reasons, which I'll touch on later, but that's the basic electrocardiophysiology. Can anyone guess? This is a Menti slide now, so moving on to the next one. What is happening here? I want, it should be an open box. Hopefully you can fit it out. So see if you can see a weird pattern on the ECG, or a feature that seems a bit unusual. Actually, I might give you a clue. Let me point at them. What's happening here and what does this mean? Let me know if you can actually, just because I'm not used to open questions on Menti. I see people, I think people are replying. If there are numbers in the bottom right, Anush, does that mean people are actually saying things?
Usually, yes.
Okay, sweet. In which case I'll do a countdown. Oh, that's a minute. No. Okay. Is there any? Oh, I can close voting now. Oh. but just have a think. So the green arrows are pointing at a bit of a clue, but can you tell me what this means in terms of the depolarization of the heart? Okay, let's close the voting. And then how do I look at the answers?
They should come up. I can't remember without it being in front of me because
it's not working. Show results. Here we go. Perfect. Inverted P waves. Great. So a lot of you have commented on the inverted P waves. Very good. Someone's asked if this is a miscalibration where the electrode is not placed on the patient correctly. It's a good thought, but if it's consistent across so many different ones, unless they've completely done the opposites, and the chest leads, because that's just a one place really, it's unlikely for that to be the case if everything else is normal. So well done for picking it up. But what it actually is suggesting is it's going in the opposite direction to what we expect, which is actually pointing at the pacemaker not being our sinoatrial node, but from the middle of the heart. Okay, because what's happening is you have depolarization going down to the ventricles, which is giving us our normal QRS, but we've got depolarization going up in the other way. Okay, which is why our P waves are inverted, because we're going in the opposite direction to what we'd expect. Okay, so this is suggesting a junctional pacemaker, a pacemaker originating from the AVN. This is less of a knowledge point for SBAs, but it's just a useful thing to interpret in terms of visualizing what's going on from the ECG trace. Okay, right, ECG trace. I'm going to speed through this because I'm sure you're happy with this. P wave, here are the normal limits. It symbolizes atrial depolarization. The PR interval is running from the beginning of the P wave to the beginning of the QRS. Okay, you'd expect it to be that length, and we'll talk about pathology if it's not that length. QRS should be less than 0.12 milliseconds. It symbolizes ventricular depolarization. The ST segment is sort of the bit after the QRS to the bit before the T wave. The segment means it should be sort of flat. And then T wave is our ventricular repolarization. And then finally, the QT interval. Can anyone tell me where the QT interval runs from and to?
the only time you need to read an ECG in year 5.
I've done
the
this
QT
too many
interval.
times. Particularly relevant when we're thinking about today, starting people on certain drugs. My meeting chat thing don't hang on. Q wave to the end of the T wave, fantastic. So it's from the beginning of the QRS to the end of the T wave. Okay, great. And the normal values are there. So 0.44 milliseconds in men, 0.46 milliseconds in women. Okay, great. There we go. So that's just the background. Now let's go from our systematic way of approaching an ECG, which is what I would recommend if you ever had to interpret an ECG in an OSCE. Because a systematic way, even though it might not reveal the headline stuff, will mean that you do not miss a thing. Okay, so most important thing is patient details, because it's the thing that people forget, and it's the thing that will give you marks in an OSCE. So what's their name, date of birth, MRN? You want 3 identifiers, and also the time that the ECG was taken, because often with patients we'll do repeats, so it's relevant to see whether it's changed. And then the first point is actually a really interesting point, which is why was the ECG taken in the first place? There's no, just like you wouldn't interpret a chest X-ray without a clinical indication, you shouldn't interpret an ECG without the indication for the ECG. Okay, if someone's come in with palpitations, feeling a little bit sweaty, feeling a bit lightheaded, that helps. It helps us sort of picture what it might be, and if the ECG matches that picture, it's really helpful. Okay, but then from that, rate rhythm axis, which I'm sure you're used to doing, and then we're going to go from basically the start of the ECG trace to the end of it systematically, and just comment on those. Okay. So let's start with rate, rhythm, and axis, which I think a lot of you said you were happy with before. So let's do this as a warm-up question. Just put all of them in one answer. And if you're all rocking this, then I'll just sort of speed through. Okay. Sorry, where's the Menti link? Oh. Okay, I think I copied and pasted it earlier.
Oh, I've done it, don't worry.
Fab. Thank you. My chat box isn't letting me type things anymore. Which is a bit weird.
Okay, it's fine. Yeah, I'll do stuff. This is why it's useful having
an
extra pair of hands.
But thank you. Yeah. Okay. So, rate, rhythm, axis. Sorry for the weird line in the middle of the ECG. I think this is one I actually took a photo of.
I keep seeing cool ECGs and then forgetting to take photos of them. It's really sad.
You could have sourced all my ECGs for this presentation.
Yeah, I know. Wasted.
Are the ECGs coming up okay in your slides, by the way? They're big enough in size to actually do this stuff. Okay, I've started a 30-second timer because a few of you have got your answers in, which is great. Keep them coming in. The best way you're going to learn from this presentation is from actually doing the stuff and seeing if you make mistakes or you're rocking it. Okay, great. So let's show the answers. Oh, I didn't open the voting, did I? Oh. Were people able to vote? Oh, God. Deary me. We really need to sort out VVox or something. No. How am I? Very sorry about this. Anush, how do I do this?
I don't know. Let me open it up.
Were people able to vote in that?
Can someone tell us? Sorry, I didn't have it open because I was an idiot.
No.
Did you receive an input from me?
Perfect. It was a free text box. That's perfect. But I just can't see the free text box. I can't see the answers. Hide image. Maybe. Oh, there we go. Perfect. Fab. Okay, so rates approximately 96 beats per minute. Looks good to me. Rhythm, sinus, very good. And axis, I think no deviation. Okay, some of you have put the right, which is right axis deviation. A few of you weren't quite sure about the axis, which is fair enough. Okay, all right. Someone said hi, which is cute. Thank you.
That was me to test it.
Oh, I see. Okay, right. So most of you are happy with rate and rhythm, so I'll spend a bit more time on axis, which is understandable. Perfect. So there we go. That's the answer. So well done for those who put it. Okay, so rate. I know they teach you through two methods. One of it's regular, one of it's irregular. Just go for the irregular one because it'll work anyway. So just count the number of peaks and multiply it by 6 because an ECG records 10 seconds. Okay, so there's 13 here. There's 13 here. Multiply it by 6, 72. It saves you it saves you time because you're not remembering which method you use. B, it's quite hard to divide 300 by 2.7 squares or something. So you may as well multiply by 6. It's more accurate this way anyway. Rhythm. Basics are basically looking at P-wave, looking at QRS. Firstly, are the P-waves orientated correctly? So the one that I showed you previously where the P-waves are inverted, they weren't, which means it wasn't sinus rhythm because it wasn't originating from the sinoatrial node. If the P-waves are oriented correctly and look a normal shape, then yes, sinus rhythm. All sinus rhythm means is it's a depolarization of the heart which begins at the SA node. So you can still have sinus rhythms where there's pathology involved. It's just that it means it's coming from this SA node. Secondly, the P-waves followed by QRS. Then they broadly talk about whether the ECG is regular, regularly irregular, or irregularly irregular. I've got some examples of the regularly irregular and irregularly irregular because I think it's really confusing. So regularly irregular is if they don't happen at a fixed rate, but there's a pattern behind it, you can see it. So an example is Mobitz type 1, where there's a pattern, you can predict what's happening. Or in respiratory sinus arrhythmia, where the heart rate increases on inhalation and decreases on exhalation. Okay, this is normal. You see it a lot, particularly in kids. So those are regularly irregular. There's a pattern behind it. Irregularly irregular is when there's no fixed rate, no pattern behind it. You can't really predict it. And this is an example of a very classic irregularly irregular rhythm, which PassMed uses as an almost sort of buzzword for a certain condition. Can anyone tell me what's the classic irregularly irregular rhythm? Oh yeah, very good, atrial fibrillation. So I think, broadly speaking, for the purposes of your exams, if you see irregularly irregular, it is fair enough to think atrial fibrillation. In real life, atrial fibrillation is not the only one that can cause irregularly irregular rhythms. So if you speak to a cardio reg and go, oh, it's irregularly irregular, I think it's AF, don't be surprised if they sort of face palm. But don't worry about upsetting cardio reg, as anything can upset a cardio reg.
If you say that to a general medicine doctor, they will probably agree with you.
There you go. I've not gone too much into arrhythmias because I didn't want to keep you for an hour. Maybe we'll do another session on it if there's enough desire. Let me know in the feedback. Okay, axis is the one we want to spend some time on. So what axis really means is if you can summarize the direction of depolarization in the heart in one direction, what would it be? Okay, worth then knowing a normal axis is -30 to 90. What do the numbers mean? Well, it's weird. It's done it in a weird way. So brought like across is 0 degrees, okay? And then you go anti-clockwise, so going straight down is +90, going up is -90. And the reason why it's +90 going straight down is because the heart is more commonly pointing down than pointing up. We talked briefly about the lead positions, yeah, the arms, the limb electrodes, and generating the directions. This is super mega useful for axis, because if you can think about that and draw it, you can summarize it into this. Okay, and within this, we only are interested in 2 electrodes. If we think about a direction of an arrow, we can broadly split it into how far does it go horizontally and for how far does it go vertically. And that's why we look at leads 1 and ABF. Lead 1, which is our horizontal line, and lead ABF, which is going straight down, which is our vertical line. So when we're looking at axis, we want to look at the part of the ECG trace that is clearest. Okay, and QRS, because it's so tall, usually is a very easy one to look at. Okay, so broadly speaking, we want to see if the QRS of the ECG trace is mostly positive or mostly negative. Okay, if it's mostly positive, it means it's going in the same direction as that electrode. Okay, so if it's mostly positive in lead 1, it means it's going that way. And then if it's mostly negative, it means it's going in the opposite direction, which is why I've done the dotted lines. Same with AVF. Is the QRS complex mostly positive? If yes, it's going down. If no, then it's probably, if it's negative, then it's going up. Okay, so let's work through this example together. So this is an ECG. I've just took out the ones that you need, lead 1 and lead AVF. The QRS is positive in lead 1, which means it's going in the direction of lead 1. It's going to the right. However, when we look at the QRS and AVF, it's going down more than it's going up. So the QRS is negative. That means it's not going downwards, it's going in the opposite direction. It's going up, which means we know that it's somewhere there in that upper right quadrant. Okay, if you can do that with all ECGs, then you'll be fine with axis. The final finessing point is that you'll remember that the normal axis is annoyingly not 0 to 90, it's -30 to 90, because we can allow a bit of a leeway. And the trick for that is our perpendicular rule. Okay, so then you can look at lead 2. If it's broadly positive in lead 2, it's going to be within that -30. Okay, because if you look at the -30, that's perpendicular to lead 2. So lead 2, if it's positive, it's going to be within the normal axis. If it's negative, it's going to be in the other direction, so it's going to be left axis deviation. Okay, let's do one more example, and I won't go through it. I'll leave this for you guys to navigate in Menti. Okay, so what is the axis of this one?
And some of you might have heard mentioned in teaching, leaving and reaching, and this is the basis on which that mnemonic has been created.
Yes, I make reference to that in my notes. I prefer doing it this way, because if you can get this, then you can get other parts as well. It's useful. And sometimes the leads aren't always positioned in the way that makes leaving and reaching easy. The lead 2 might be next to it rather than below it. But choose what works for you. Okay, so if you want the sort of easy mnemonic, that's in the notes of this slide. Okay, 5 seconds until voting closes. Okay, so hopefully, there we go. So everyone who answered was absolutely spot on. Okay, it's right axis deviation. And that's because lead 1 is broadly negative. So we know instead of going this way, it's going this way. And then lead AVF is positive, so then we know it's going down. So it's going to be in that quadrant, in the right axis deviation quadrant. Perfect, well done. So summary and a final test for you. Calculate the rate, rhythm, and axis of this one. Oh, sorry.
While you're doing that, just one other thing I was going to mention. I don't know whether you might have been taught how to calculate the exact angle of like axis in one of your lectures. Like I just don't. I'm sure James agrees with me. That's just not useful to know.
There is absolutely no clinical relevance of knowing whether it's 31 degrees or 29 degrees.
Yeah.
Just don't.
So ignore that lecture. Well, that bit of that lecture.
Yeah, I agree. Okay, so rate, rhythm, and axis, and then we'll go on to systematically talking through the rest of the ECG. We're making good time, which is good. Well done, team.
The exciting bit is once you've done rate, rhythm, and axis.
Absolutely. Well, I'll give you a bit more time. 2 people have answered, 3. Here we go.
If you get axis, you can get the rest of ECGs. This is the most challenging bit of an ECG, figuring out how an axis works. I didn't know this for like 2 terms.
Okay. I'll give you a 10-second countdown now, and then we'll get going. 5 of you responded. Let's see if we can get a few more from you. Okay, great. So let's have a look. See. So rate 126. Well done. For those of you who said it. Rhythm, sinus rhythm. If you want to be specific, sinus tachycardia because it's over 100. Axis is actually left axis deviation. So a few of you were a little bit confused at the axis again. So if you want me to talk through it at the end, feel free to hang on to the end and we'll discuss it again. But the most of you who went for left axis deviation was great. Fab. So localization. It's a bit out of place here, but it's useful because we were just talking about lead groups. So I know some people like to rote learn which leads mean what. Not that helpful. If you just look at this diagram, the ones that are lateral are the ones that are going in that direction. Okay, so lead 1 and AVL. Alongside those, we're just going to look at the lateral chest leads, the ones that are furthest to our left. So V6, V5. That's our lateral group. Nice and easy. Inferior, again, look at the diagram, which ones are pointing down. Right wrist to left wrist, 2. Left wrist to right wrist, 3. And then AVF. So those ones are going to be our lateral groups. Inferior groups, sorry. And then the rest are just on your chest. Okay, so V3, V4 are anterior, V1, V2 are septal. So you can think of V1 to V4 as anteroseptal. Worth noting that the majority of these groups are referring to the left ventricle because the left ventricular wall of the heart is so big. But yes, no point remembering this. Just think about how you calculate it if you're happy with the lead groups. Fab. Moving on to the rest of it, the more exciting bit, as Anush says. So starting with P waves, or more, to be more specific, no P waves. So what do we call it when, actually no, yeah. So P waves just indicate that the sinoatrial node is not working. Okay. If the QRS complexes are narrow, and the beats per minute are more than 100 beats per minute, therefore it's as in a tachycardia, it's suggesting that it's a supraventricular tachycardia. Okay. Which all it means is it's an arrhythmia where the pacemaker of the heart, i.e. the start of the depolarization is supraventricular. It's above the ventricles. So in the atria or in the atrioventricular node. Okay. What does the narrow QRS complex actually mean in terms of depolarization of the heart? Why does a narrow QRS complex tell me that it's a supraventricular tachycardia? Atria is smaller. Jordan's hit the nail right on the head. Exactly. So QRS being narrow means that it's that the ventricles are being depolarized in a very rapid, normal way, as in the depolarization has originated above the AVN because it's being conducted down the bundles of His really quickly. Okay. If it's broader, it's suggesting that the depolarization isn't happening in as much of an ordered way. It's not going down our bundles of our conduction bundles, which suggests it's originating below the AVN or from the ventricles. Okay, so whenever you see a narrow QRS complex, you know that the ventricles are depolarized from somewhere above them. Okay, well done, Jordan. Okay, supraventricular tachycardias are a very broad area, and they can include all of these. Okay, there's two main things under the P wave heading that you should be able to identify, and they're over here. Okay, which one? What's the one on top? What's the one on bottom? From their weird shapes instead of the P waves. Very good. Atrial fibrillation on top. You can see those fibrillatory waves. Sometimes they're not so obvious. Flutter below. Fantastic. Yeah, you've got clearly here these sawtooth sort of things instead of the P waves, which symbolize atrial fibrillation. So fibrillation and flutter are slightly different. So fibrillation suggests that the atria are beating very, very rapidly, but also irregularly. There's no pattern to it. And that's why you get an irregular rhythm, because there's no pattern to it, and it's just the random lucky atrial depolarization that leads to one of those QRS complexes that get conducted. With flutter, they're also beating very fast, but it's beating at a regular rhythm. Okay, so the atria will be beating very fast, usually 300 beats per minute, and the AVN transmit them at a regular pace. So you usually get a regular sort of 150 beats per minute from the QRS complexes. Okay, very good. This is a very minor point. I'll leave you to read it in your own time. The notes are very explanatory, but this is how you identify left or right atrial enlargement. And if you consider our sort of cardiophysiology, where it's starting from, then it really makes sense. Okay, Menti for you. This one is an SBA, I believe. Yeah. So, patient comes in complaining of palpitations and lightheadedness. That should already give you a clue. You measure their pulse to be 180 beats per minute. The ED nurse has yet to take an ECG from them, but you're aware that they have a cardiac history because you've got an ECG that was taken, let's say, a year ago. So, now that you've seen this ECG from a year ago, not their current one, how should that affect your planning for what drug they should not be taking? Bit of a weird question. I know UCL don't usually like negatives, but I think it's an important learning point. Oh, let's make it 30 seconds.
Also, while you're answering that, generally a good rule is if you spot no P waves, that is AF until proven otherwise, and you should look for evidence for things that are not AF, because probability dictates that it is AF, because it is the commonest supraventricular tachycardia that isn't sinus tachycardia. But if you're really running out of time, that is the assumption you should gun for, purely from a probability perspective.
Very good point. Unfortunately, medicine is very much about probabilities, which doesn't often get relayed to our teaching. Okay. This is a really mean question, and I'm sorry.
This is a really mean question.
Okay. So the distribution of your answers almost has me self-doubting whether I picked the right answer, but the answer is adenosine from my point of view, and Anush can step in and interrupt if not. And I'll go into the reason why in a few slides. Okay, bit of suspense. So we've done the P wave, now the PR interval. Okay, PR interval should usually be 3 squares, so 0.12 milliseconds, or 5 to 5 squares, 0.2 milliseconds. If it's too short, like here, then it's a pre-excitation syndrome. If it's too long, then it's probably AV node block. Okay, so let's tackle the pre-excitation syndromes first. Can anyone see the pathology here? It's quite, yeah. So first of all, you can see the PR interval is tiny. It's probably only 2 squares, if that. So we know it's a pre-excitation syndrome, but there's another feature here that suggests a certain pathology. Very good. Wolff-Parkinson-White, exactly. The delta wave is what we're talking about here. Well done, all of you. So that's sloped QRS. It's not just straight, okay? And that's suggesting something called Wolff-Parkinson-White. So that's caused by an accessory bundle that joins the atria and the ventricles. So in our normal graph of a normal depolarization, we said that it's held up slightly at the AV end before it goes down the bundle of His. Instead, here you've got this bundle of Kent, which sort of gives you a shortcut from the atria to the ventricles. And because it starts just before the main depolarization, because it's usually held up, then that's why you get this sort of slope to it. It's not this regular thing. It's just there's something that's pipping it in the post. Okay. And this is another one where you don't see the delta wave. This is much more minor. They call it Lone-Ganong-Levine syndrome. They don't even know if it's pathological or not. It could just be a normal variant. So this is less important, but for sake of full completeness, here it is.
I think it's also worth pointing out that if they give you Wolff-Parkinson-White in an exam, that's going to be one of the toughest questions in your paper. This isn't like it's still, I wouldn't call it like a barn door ECG. It's still like your exam will have tougher questions because they want to produce that normal distribution. So this will be one of those tougher questions. So if you, by all means, learn it. But if don't get stressed about it right now, please.
Speaks the truth. But yes, so the extra point with Wolff-Parkinson-White is because you can imagine that you've got this accessory bundle. When we are talking about medications, and we really don't want to block the AV node, because that just means all of the electrical impulse doesn't go down the AV node in the normal way. It just goes down this accessory pathway instead. Our AV node is a really good filter. So that's why in atrial fibrillation, we only see a QRS every so often. It's not transmitting all of the atrial signals. If we block that and then instead leave the shortcut, then all of the atrial depolarization and things just go straight through to the ventricles. So that means you can trigger ventricular arrhythmias and then sort of asystole and awful things. So you need to avoid AV node blockers in anyone with Wolff-Parkinson-White. Adenosine, which we use for supraventricular tachycardias to sort of briefly halt the AV node, but there's other things like verapamil or beta blockers that you should tend to avoid in those patients. Okay. Although a good learning point for the others that usually benefit of the doubt, if you're not quite sure, amiodarone is probably a good answer because there's quite a lot of side effects and it's quite a dirty drug. So well done for going with that. Actually, it's good SBA skills, street skills. Okay, another Menti. Another mean question, but if you can get your way through the reasoning or you can identify what's going on here, then you should be very proud of yourselves. I was just in a terrible mood when I wrote these questions. I'm sorry.
I'd argue that this is quite classic. This is quite a classic ECL question.
Good. Okay, fab. But you can still feel fine if you don't get it.
Yeah,
okay.
Your exams aren't like for eons.
Let's give you 40 seconds. 50 seconds. Okay. Once you've had your answer, I want you to put prepare in the chat what you think you can see in the ECG. What's the pattern that we've got here? Oh, very interesting. There was one answer option that was shooting up at the beginning, and now there's more and more people going for another answer. It's good to see the battle between them. Oh, and one has prevailed. Okay. So first of all, for the majority of you that went between the two most popular answers, I think you're thinking along the right lines, which is great. Can anyone post in the chat what the arrhythmia that you can see here is, or the pathology? Oh, okay. It's Mobitz type 1 because what you can see is that the PR interval is gradually increasing between the QRSs. Okay, so I can't point it out with an arrow, but look at I don't know why it's labeled PAU, but look at PAU1. You can see PR interval there. Then the next one is going longer. Next one is longer. Next one is longer, and then it's dropped. Okay, so that's Mobitz type 1. Mobitz type 2, what you typically see is a regular PR interval, whether it's prolonged or normal, and then suddenly one has dropped. Okay, so if you thought it was Mobitz type 2, absolutely right, you give them a pacemaker. Okay, because that's unstable. Mobitz type 1, however, is not pacemaker worthy. It's very common. It's a normal variant, and we don't need to intervene. Okay, so the correct answer is actually send home with appropriate safety netting. And this is another learning point for you. We had a talk from Doug McKechnie, who went on an SBA writing course and writes a lot of our SBAs, and he gave us some quick tips. And one of the tips is that a lot of the harder questions, the differentiator questions, the correct answer is actually the conservative measure, because they know that med students find it really hard to not go with the hard and fast dramatic interventions. So if it's the correct answer in safety netting, then that is perfectly an okay answer. Okay, so Holters, the reason why you wouldn't give atropine is because he's feeling fine, and you give atropine for a bradycardia, but he's not symptomatic. You wouldn't give a 24-hour Holter because you can see the pathology here already. Yeah, you can see why he's feeling like his heart skipped a beat. You don't need an extra days of recording. The repeat ECG on treadmill you tend to only do, it's a bit outdated now, and you tend to only do it for sort of coronary artery disease. So I think it's like second or third line now after CT coronary angiogram. Insertion of pacemaker, absolutely right if it's Mobitz 2, but it's not, it's Mobitz 1. And then so the correct learn. The way that it was always told to me is in terms of which one needs pacemakers, which one doesn't. So with first degree heart block, think of it as someone in your firm who turns up 5 minutes late to every teaching session. Okay, bit annoying, but it's fine. You're not worried about them. Second degree heart block, Mobitz type 1. They come 5 minutes late on Monday. They come 10 minutes late on Tuesday. They come 20 minutes late on Wednesday. And on Thursday, they just don't come at all. And because it's sort of coming, you almost expect it. Whereas with our Mobitz type 2, they come on time on Monday. They come on time on Tuesday. They come on time on Wednesday. And then Thursday, they're not there. Then you're like, oh, what's happened with them? You know, are they okay? And that's why you need to put a pacemaker in them. You also need to put a pacemaker in third degree heart block. The easiest way to tell if it's something's third degree is draw the P to P wave intervals and the QRS to QRS intervals, and they'll be regular, but there won't be a sort of relation between them. Cool.
Third degree heart block is the hardest thing to confidently say out of all of these.
Yeah,
doctors get it wrong on a really regular basis. So whenever you get an ECG, like mark it out, as James said.
Yeah. ORS complexes now. So this little table is just useful to sort of understand what the different components of the QRS is. So Q is actually the negative deflection that happens first before the QRS. R is the big positive deflection. S is the big negative deflection. Sometimes you get repeats, and that's why you have a repeat letter with the apostrophe. Okay. So there you go. So R dash is the second positive deflection that happens after an S wave, and that is not normal. So that sign, there's a sign of pathology. It should be less than 12 milliseconds in length. If it's prolonged, if it's narrow, we've talked about what this means about conduction. But if it's broadened, it either means that depolarization is happening in the ventricles because it's not coming down in this really nice bundle of His, or that there's bundle branch block. So there's something that's affecting that, which means it's not depolarizing as quickly as we think it should. In terms of differentiating between right and left bundle branch block, your friend is the RSR, which I've got circled there. So if you see those two upward positive deflections, that will tell you there's bundle branch block, and it'll tell you where to. I will leave the stuff in blue for you to read later. So here you can see the RSR pattern here in V4 and V5. Yeah, it's that second positive deflection. Because it's in V5 and V6, sorry, V5 and V6 is in the left side of your chest, so that's left bundle branch block. Whereas here, you can see the RSR pattern over here in V1 and V2. V1 and V2 is on the right side of your chest, or more to the right, so therefore it's right bundle branch block. I know there's also William Morrow, but I'm rubbish at seeing letters and ECG traces, so I prefer this. But William Morrow can also be your friend if you like it.
They'll make, like, I'd wager that it'll be an obvious one if it comes up. And it's more likely to be, yeah, like if it comes up, it'll be fairly obvious that they have a bundle branch block.
Yeah.
None of this, it may be, might not be stuff.
Yeah. Q waves, read in your own time, but it's a negative deflection. It can be normal, but if it's really deep, it's probably pathological, and it suggests transmural infarction. So difference in infarctions in MI, either it's subendocardial, so it's not, the entire muscle is not infarcted, or it's transmural, the entire muscle has infarcted. So transmural MIs, signs of those are STEMIs, so ST elevation, or this Q wave, and then N STEMIs will give you the subendocardial MI. So it's not all of the heart muscle that's died. Read in your own time. Here we go. Menti. "56-year-old diabetic man complains about abdominal pains and not feeling too well. ED takes an ECG, which you can see on your left. What's the pathology?"
This will be the majority of your ECG questions in an exam. We had like 5 of these in our year 4 paper. I don't know how many you had, James, last year.
I can't remember, but a few. It's very high yield, so getting it right in your head is really important.
They really don't want you to miss this as an F1.
Okay, 10 seconds, 15 seconds left. Cool. Okay, so the majority of you went for the correct answer, and the rest of you were split, 2 each on all the others. So the correct answer is A. Okay, so first of all, people are thinking, oh, it's a STEMI, but he's not complaining about chest pain. They will try and do this to trick you. There's 2 clues here that suggest it might not be a typical presentation. A, they're diabetic. Also, the elderly tend to have atypical presentations. And B, abdominal pains can be a sign of inferior MIs because it's lower down. Okay, so inferior MIs can be referred to the abdomen. So here you can see there's ST elevation in lead 2, lead 3, lead AVF. Okay, you also have ST depression of V4 and V5, but that doesn't help as much. So 2, 3 AVF, if you think about the directions of those leads, they're all pointing downwards. So that's an inferior MI. It's a ST elevation, so we know it's transmural, not subendocardial. I can see why people might have gone hyperkalemia because the T waves do look a bit tall, but I'll talk about that later. So ST elements. I actually found it really hard to tell the difference between ST depression and spot ST elevation. So my trick for you, if you also have similar difficulties, is look before the QRS and look after the QRS and compare those 2 points. So on this diagram from A to F, they all are a certain type. Are they ST elevation or ST depression? ST depression, exactly. Because if you look before the QRS and you look after the QRS, it's lower. So ST depression, and it can be a sign of N STEMIs. It can also just be reciprocal changes if you've got ST elevation elsewhere. It can be a sign of strain, particularly if you also have left ventricular hypertrophy, and you have this weird particular shape in digitalis. So digoxin poisoning, you have Salvador Dali's reverse tick or the Nike reverse tick. this was tested once, but it's really rogue and a very, very hard question. So learn it if you like, but yeah. So NSTEMIs suggest what type of infarct? A subendocardial or a transmural? Subendo, exactly. Yeah, it's not quite so serious. Good. So here, if you can compare with the previous slide, you look before and look after the QRSs, it's much, much higher afterwards. So this ST elevation. And the most alarm bell ringing thing that you should see is STEMIs when you see this. You can also see it in pericarditis if you have global ST elevation. So all of the lead groups have ST elevation. And Takotsubo, weirdly, can also mimic STEMIs, but don't worry about that. Here are the lead groups. Remember how you could generate them with the limb leads. It makes it so much easier. Another useful thing is being able to spot the reciprocal ST elevation depression. Okay, so the thing that will differentiate you from a STEMI and pericarditis is that pericarditis consistently has ST elevation across lateral, anterior, septal, whatever. Okay, in STEMIs, you should expect to see ST elevation in a lead group of a pattern, but you should also expect to see depression in another group. Okay, and the way to remember that is the mnemonic PALES. So a posterior MI will have anterior depression, an anterior MI will have inferior depression, and so on. Okay, so if you learn PALES, that will help you spot where the depression should be.
The posterior one is super important and comes up because you can't look for the ST elevation. So if you were going to learn one of those, it's the posterior one.
I'll show you how we get that in a second as well. So once you know the lead groups, you need to know the arteries. This is just rote learning. I won't cover it too much, but there you go. So lateral, posterior circumflex, anterior, left anterior descending, down the front of the heart, inferior, right posterior descending. Okay. Okay, so I think this, yeah. So another question for you on Menti. Where is the infarct? Or describe what you see and what does this mean?
This is the most useful ECG thing I learned in all of fourth year.
I'm not sure I get what you're referring to. Maybe you can explain this slide. Okay, one of you's described it. Just in the interest of time, because I know we're kind of getting to an hour soon, I will give you a 10-second countdown and speed through the rest of the slides. To be fair, ST elevation and depression is definitely very high yield, so I'm glad we've covered this properly. Okay, let's cast the time on. Let's have a look at what you've said. Okay, great. So a lot of you picked on this. Yeah, so you've got ST elevation in V1 to V4, and you have ST depression in lead 3, and you should also have it in 2. Okay, so you've got...
Can I just add one thing? Yeah. So you see those T waves in V2 to V4 with the massive elevation. If you see those and your patient is like, okay, they won't be okay in a minute. Those are hyperacute T waves, and that means they're about to have an MI. It's really useful to spot in A&E.
Yeah, really good point. So a lot of you picked up on the T waves. Well done for recognizing it, but they're not tall-tented T. Oh, hang on, I labeled them as tall-tented T waves. They should be. What Anush said. So what did you say again, Anush?
Hyperacute T waves.
Hyperacute. And the reason why they're hyperacute is because tall-tented T waves tend to be symmetrical. You can see with this T wave, it's sort of sloping on one side and not as and a steeper gradient down on the other. So I'll relabel these slides. These are hyperacute T waves, which suggest an impending MI. They're an earlier sign ahead of ST elevation. So the way you can tell between tall-tented T waves of hyperkalemia, sorry, I made this presentation half asleep, and the hyperacute T waves that Anish refers to is hyperacute tend to be less symmetrical, whereas tall-tented T waves have one up and one down. Good. but anterior STEMI. So here's what Anush was talking about. So here you can only see depression in V2, V3, V4. Okay, so some people might go, oh, is this an end STEMI? But no, one thing you really, really need to think about is whether this ST depression in V2, V3, V4 is actually just this reciprocal depression of an posterior MI. A quick way to screen this if you're an A&E is turn the whole thing upside down. Okay, so when we turn it upside down, these waves almost resemble ST elevation. Okay, and that should be the signal that you want to be putting on electrodes at the back. Okay, that we call V7 to V9. So I don't think you really need to know where you place those, but you sort of place them around the scapular wall. Okay, and when you place them on the scapular wall, here we go, V7, V9. There we go. We've got STEMI, ST elevation there in V7 to V9, which is suggestive of a posterior MI. Like Anush said, this is really important to spot because if you just half glanced at it and saw depression and didn't think much of it, then this guy could not get the treatment he needs. But posterior MIs do happen and do need to be picked up. Okay, so isolated ST depression in the anterior ones, so V1 to V4, just turn it upside down, and if you even have the slightest of suspicions, just order another one with V7 to V9. Okay, T wave. There's a few patterns to look out for. What do we see here in this picture? Tall tented T waves. Here we go. Exactly. So you can see it's much more symmetrical and it's very tall as well. So amplitude. So if it's more than 5 millimeters, so 5 mini squares in the limb leads, or more than 10 millimeters in the chest leads, then it's going to be these tall things. Yeah, so it's tall tented T waves, which suggest hyperkalemia. Here, what do we have here? And what might it be a sign of? Very good. TWE or T wave inversion. And what does T wave inversion mean? It could mean STEMI. It could also mean hyperkalemia. So I should put that on my slides. Very good. And then finally, hyperacute T waves, which we see here. You can see they're tall, but they're not quite so symmetrical. And that's an early sign of a STEMI. And that happens before your ST elevation and your Q waves. So like Anush said, really important to spot first. QT interval, like we said, from the beginning of the QRS to the end of the T wave, because it's so proportional to your heart rate, you need to correct it. So you need the QTC. This is Bazzett's formula. Don't know if it's worth remembering. It might be useful. You can just use the MD calc when you're an A&E. But the reason why it's a useful one to know is because the ECG can calculate it for you, but it's often wrong. Okay, so most of the time, well, or most of my 5th year when I've been looking at this, I've been doing it manually, and you should. Okay, but like Anush was nodding vociferously, use MD calc. Don't worry with the formula. If it's more than 440 milliseconds for men, it's prolonged QT. More than 460 for women, it's prolonged QT. What do we worry about with prolonged QT intervals? Say, yeah, let's have a look at answers. Torsade, very good. So torsade de pointe, very good, which is a very irregular rhythm that can lead to ventricular arrhythmias and sudden cardiac death. So we worry about this in people with long QT syndrome when we start them on certain drugs. Clarithromycin being a really important one from 4th year to know that there are more. Okay, so we've gone through everything I think you need to know about ECGs in a very systematic way. Let's put this into practice. This is an ECG. This is the man. He's a 55-year-old man presenting with central chest pain and diaphoresis. See if you can run from start to end. And let me open up Menti. So hopefully you have the space, but describe everything you can see from the rate rhythm axis to anything that you note about the P waves, PR interval, QRS complexes, ST segment, T wave, and don't worry too much about QTC. If you can do this from start to finish and you're happy with every step of the way, then you will be an ECG ace. I think you can send in multiple answers as well. So if you want to chunk it as to the bits that you've done, then just send it straight through.
Also have a read of the management of hypokalemia. It's not really emphasized in the curriculum as much as hyperkalemia, but it's like, and I don't think it will come up. It's less likely to come up, but it's still quite important because you will be doctors in a couple of years.
Isn't that a scary thought? You're going to be a doctor in 4 months' time, Anush.
Let's not talk about that.
You'll be a great doctor, it's fine. Okay, one person has answered. Great job. Keep those answers coming. We're pretty much at the end of the presentation, guys. Yeah. If any of you are going to leave early, the rest of my slides have a few slides about spot diagnoses from ECGs, and then a few more practice ones like this. So do feel free to check this out in your own time. But hopefully this should be a good set of slides to come back to.
And if you leave early, please fill out the feedback as usual.
Yeah, I appreciate this is very different to this type of teaching styles we usually do, and it's because I really struggled to fit this in. We'll post it on the treasure trove now, right, Anush?
Yeah, it's all on the trove. I just need to wait. Yeah, it will be on there. Hopefully by the end of Easter weekend. Most of it is on there. It's just the odd one here and there. James, I've given you edit access, I think.
I think so. I can upload this one tonight.
Yeah.
Okay. Oh, someone's really lost. Okay. If you want to stay at the end and I can talk you through bits that you're finding difficult, then I'd be very happy to do that. So let's start with the rate, rhythm, and axis. Okay. So rate 48 beats per minute. Absolutely right. Well done. So you've counted 1, 2, 3, 4, 5, 6, 7, 8. 8 times 6, 48. Lovely. P waves and rhythm. Well done for the people that have pointed out that there's no relationship between the P waves and the QRSs. Okay, you could draw. It's sometimes hard to spot because the P waves are kind of hidden amongst some of them and there's a bit of distortion. But yes, this is suggestive of third-degree heart block. Axis is normal. Very good. So P waves, they are present, but like we said, they're not related to anything. The PR interval, we can't really describe because there's no relation between them. Okay, QRS, they're pretty small amplitudes, but nothing more to comment beyond that. T waves, nothing much to see, and there's no U waves. So the thing that you really need to pick out is the ST elevation. Okay, so you can see ST elevation in 2, 3, and AVF. Okay, which is suggestive of an inferior MI, as a lot of you have referred to. Okay, so the person who even said inferior MI, don't know, to be honest. You got it right, so well done. But the reason why I wanted to stress going through this structured way is because if you just pick out the inferior MI, you don't pick up the the bradycardia, and B, you don't pick up the fact this is also complete heart block. And this is very common in inferior MIs because the artery that supplies the AV node is the same one that supplies the area of the inferior things. So if you lose the supply in an inferior MI, you also lose the supply to the AVN. So you then don't have a relation between your atrium and your ventricles. So very good. Perfect. Okay, so thank you for coming. Here's some feedback forms. Please fill it in. What I'd really like to know is A, was this a bit too boring? Was this a bit too theory-based? Would you have liked to have a bit more sort of case-based stuff? B, do you want another one on arrhythmias and things? Those are the two things that I'm wanting to know. But anything else, if you have advice that I can do to improve the slides, if you can teach me how to use Menti properly, sorry. Any feedback would be welcome.
Yeah, and if you're a bit lost, stick around.
Yeah.
And we can talk about some cheat ways that you can use if you're really lost. But like this is like the ideal way you would do it in real life.
But for reference, here are the other slides. So just a bit of spot diagnoses, and then a few more sort of put into practice slides where everything should be described in your notes. Okay.
What might be useful is if you do these with your firm or whoever you're doing OSCE practice with, you can use these to practice.
Exactly. And if you have any questions, just drop me an email. It's just james.kai.16. Yeah, if you run out of the practice from these ones, this website is fantastic. It's very much postgrad, but you can still look through the features and pick up things. Okay, so feedback would be very welcome. And like Anush said, please stay if you want to talk through things that you're finding difficult, and I've got plenty of time. You're very welcome. Thank you for coming along as well.